client companies. So most of my personal experience has been related to this, as well as this is what has generated Mercer's point of view in the industry. We do believe that telemedicine is at an inflection or a tipping point and really poised to continue to take off and grow rapidly. We think that telemedicine is not a substitute for primary care, rather it's an adjunct to. It helps to plug the gaps where you don't have service providers available or where you need specialty assistance that might not be locally available, or you have an acute care, which we'll look at. There's been a lot of talk in the media of late of some variability in quality of care with telemedicine, and concern is it somehow a substandard kind of care for that reason. And what I would say to that is medical care in itself is more of an art, but it's both an art and a science. Human beings are complex, right? So there's going to be variability in care no matter what avenue you access it through. I guess the key question would be to reframe that a little bit and say, is there any more variability in care rendered through telemedicine than what we see in brick and mortar? Early indicators are we have not seen that. In fact, there might be less, and you'll see why as we go through the conversation. Services continue to expand. We'll spend a little time talking about how that's happening. And you'll hear this, I think, consistently throughout the day, and it'll kind of be wrapped up by another speaker too. The value that you get from telemedicine is really directly inherent to the amount of engagement and utilization that you get. So it's not one of those things that you just put it in and they'll come. You have to really actually promote it and do some special things to make people take notice. So we'll talk about that as well. So a little bit of an overview just to ensure, excuse me, we are all on the same page. What is telemedicine? We define it as really any health-related services that are delivered via telephonic or technology. I have some water here, pardon me. So it traditionally includes acute care services, the ability to prescribe prescriptions, and the claims are processed by the health insurance carrier. Why do people use telemedicine? It's really for the features of the enhanced access, the appropriate care that can be rendered in the moment, and to avoid cost. We see increasing numbers of physicians really getting involved in the practice of telemedicine. We see an increasing number kind of devoting sole practice to telemedicine. We see employers continuing to adopt this, and as I mentioned, our collaborative continues to grow. We see this as one of the fastest growing services in care delivery. These numbers come from our annual Mercer survey of healthcare, employer-sponsored healthcare, and you can see in the last 3 years, the adoption of telemedicine has more than tripled in incidence. Today, most people are accessing these services through their health plan as an included feature or function of that service. As the employer size grows, we see more and more people going the specialty vendor route. Who are the providers that perform this service? Again, I think some may have a misnomer that these are kind of the dial-a doctors that might be lesser quality, and that's really not the case either. These are board-certified, credentialed, really highly vetted vendors, or providers rather, that are highly qualified. How does telemedicine work? You know, you do, excuse me, something in my throat today. You do need to fill out a medical history form of sorts to have on file before you use these services. As an employer, if you adopt telemedicine services, we really encourage you to get your employees to do this in advance, to get registered for the service and to complete this form so that when they have an in-the-moment need, they can, you know, more quickly access the service and not have to take time when they're not feeling well to do that. The two primary methods that people use to access telemedicine are really phone or video conference. If you're going to go the phone route, you simply call a number. You'll probably speak with an intake person who will understand what your needs are, give you either a direct connection to a physician, or the physician may call you back in a few minutes. If you want to go the video conference route, you typically will log into a website with your credentials. You'll search from a variety of available providers. You'll pick one and, again, have sort of a FaceTime or Skype-type experience through Video Connect technology with the provider who will, you know, assess your condition, give you treatment recommendations, and if necessary and very frequently prescribe a prescription, because those are the sorts of issues people really go to telemedicine often for. Acute conditions are the most primary used services, things like allergies, conjunctivitis, ear infections, rashes, that sort of thing. upper respiratory infections. We see kind of growing use and expansion into the chronic care continuum, so people that need ongoing monitoring of a condition that they have, and behavioral health, which we'll talk some more about. Telemedicine is also appropriate for some primary care kinds of services, counseling about tobacco cessation, diet and nutrition counseling as well. So originally, the value prop with telemedicine was really to expand access to those people in geographic areas that didn't have a local provider network that was sufficient to meet their needs. That's still the case. It's still important for that. It can be challenging to attract physician providers to set up shop in some of these areas too. So individuals that live in these remote areas often have a perception that the provider they have access to might not be as high quality as they might like. And so even if they have access to care, they might think it's substandard. So telemedicine can help solve for this by putting them in place with specialists and specialty care, outside of the area. One of the key value props is really the control of cost, and that's primarily achieved through diversion of care from other resources. So without telemedicine available, a lot of people say they would go to the emergency room or urgent care. Those are higher cost per unit of service, ways to access care, so that's part of the key value proposition. Increased productivity and reduced absenteeism. A telemedicine visit on average can be completed within 30 minutes, start to finish. And the estimates for seeking on-site care are more like, a few hours when you consider the travel time to the provider's office. You usually spend time in the waiting room, then you're seen and you travel back. It could be 3-4 hours, out of your day. So it really is a productivity boost and helps keep people at work when possible. Member satisfaction is a key piece of the value prop. When you're a parent and you have a sick child on the weekend or in the middle of the night, it's extremely valuable to be able to pick up the phone, talk to the doctor, and get your script called in and not have to go through that process of going to the physician office the next day, taking off of work, sitting in the waiting room with all the other sick kids, exposing your kid to them, and vice versa. To just get this done more efficiently is really a key factor in member satisfaction. And we get good quality reporting and metrics out of the use as well. So the value proposition is pretty compelling. How does telemedicine support the triple aim? If we look at our threefold goal here, drive quality, reduce cost, and improve member experience, much like we just spoke about, really quality, you can make the argument that there's more quality control measures in place to monitor the performance of telemedicine physicians on a more regular basis than those that are practicing in brick and mortar. So that's certainly in place. And the remote monitoring opportunities continue to evolve, which really help there as well. Reducing costs we talked about really by avoiding higher cost services and the productivity factor. And then the member experience. I think this is pretty redundant. Not to beat the quality control horse over the head, but when you're looking for providers, best-in-class providers will be NCQA certified, so that's something to look for. You want to ask about what are their review processes for their providers and how frequently do they review them, and what are the disciplinary processes, or if there is a complaint or a problem with customer service, how do they resolve that? You'll want to know that going in, what kind of background checks are done, et cetera. These statistics come to us from some of the premier providers about their services, and it's just further support for the value proposition of telemedicine. It can take on average 20 days to secure an appointment time with a primary care physician, whereas in telemedicine the average wait is 9 minutes. You can see the compelling proposition there. The cost avoidance, 10% on average of people that use telemedicine would have gone to the ER if they didn't have that telemedicine service available. 35% would have gone to urgent care. Productivity, we've talked about. The member experience, there's really high satisfaction with these services. We have very little incidence in our client book of business of complaints or people not being happy with the service they received. In follow-up, you can see that telemedicine actually performs a little bit better than brick and mortar. 6% of telemedicine visits result in a need for a follow-up at a later time. And when we look at office visit use in emergency department, it's higher percentages than that. Another study about does it work? This is published by the RAND. You can see very similar statistics here. Interesting one to me, access-wise, 21% of the people that use the telemedicine service had no health care in the prior years at all. So we are reaching more people who need care. It's more than just a phone and a computer. You know, to me, one of the really interesting things is to watch all the new technology devices that are now being able to be used. You know, the Kinsa thermometers and those kinds of things that are coming around. These pods are an interesting story. They were intended, or I guess expected, to be widespread use and adoption. And in practice, we hear from some of the vendors some of the issues and problems associated with it. Some people felt like they weren't really private, like everybody could see them going there to use the service, and they didn't really like that. Apparently, there were also some challenges in keeping all the equipment within the pod kind of sterile and cleaned between, you know, you got a lot of sick people going in there using the equipment, and, you know, you didn't really think about that, but you're coughing all over the monitor and the phone and others, you know, not necessarily wanting to use it. So my understanding is that use of these has really curtailed, but it's still an interesting notion to be available. So what's coming next in telemedicine? I think, you know, one of the most recent additions is the advent of behavioral health being offered through telemedicine, which is sorely needed. For me, one of the nice things about this, unfortunately, we still do have a lot of stigma associated with behavioral health services in our society, and the ability to do that sort of anonymously via this video or telephonic connection really kind of comforts people in not having to be seen going in and out of the provider's office for these kind of services. What it doesn't solve, unfortunately, is the shortage we have of behavioral health providers, and particularly psychiatrists. I was on a call yesterday and heard a rather startling statistic that more than 60% of practicing psychiatrists are over the age of 60. Yikes. So while we have another way to access, it doesn't really necessarily pump up the volume in the way that we need, but it is an important new service that more and more are adopting. I think improved integration and technology are two key issues. You know, keep an eye out. There are new technologies available all the time. I'm amazed when I see demos of how these things work and what can be done. The ability to take a picture, upload your rash or your sore throat, you know, those sorts of things, really helpful. There's more and more longitudinal use of telemedicine, so rather than just the acute, you know, sore throat or respiratory issue, really the ongoing monitoring of chronic conditions, you know, people that just need a regular check-in to see how they're doing. Telemedicine is a great vehicle for that. There's also the rise of the empowered consumer. So as healthcare plan design changes take place, we have more and more move to value-based care. There's a lot more accountability and responsibility placed on the employees for how they spend their healthcare dollar and how they access care. So to have the choice to choose telemedicine, a lower out-of-pocket cost for them, and a savings for the company, you know, a good value proposition. And then, of course, we have to consider our ever-growing millennial population and their fascination with all things technology, so it certainly fits right into their world. Workers' compensation is an area that's yet to really take off, but there's really a huge promise, I think, for telemedicine. Having worked for a while in the workers' compensation industry, I can attest to the antiquated technology that exists and just how out-of-date systems are. So it's a huge opportunity to really enhance and improve the speed and accuracy through which these services are delivered. It's been limited so far. Some workers' compensation vendors are starting to include telehealth as kind of that front-end triage option, just to at least create the electronic medical record. It's immediately beamed to everybody that needs to be involved in that case. There's good potential for use of the telemedicine as the vehicle for all those follow-up appointments, so somebody can stay at work and just check in as they need to and not have to miss their work for follow-up care. And again, special application for those people out in remote areas where care might not be readily available. So keep an eye out for that. I think we're going to see a lot more activity in the workers' compensation arena. So what does the design of the benefit look like, and what are some key things to keep in mind as you set out to do this? So if you're considering telemedicine, you don't have it yet, some questions you might want to be asking yourself, you know, what does the demographics of your population look like? Do people have PCP relationships? Are you seeing good use of preventive care, or is that something that's lacking? And even this could be an adjunct to help facilitate creation of some of those. Are you seeing high and inappropriate emergency room utilization and urgent care utilization? And is your population tech savvy? Will they use a phone or computer or not? Quality, I think we've talked a lot about, but certainly there are questions listed here that you want to be asking potential vendors, and it will help you delineate between which ones you should select. What does the pricing look like? Is it clear and transparent? Do you have a really good sense of any ancillary fees that people might incur through the use of these services? And we'll look at that in a moment. Integration. What kind of integration is going on with providers? Does a record of the visit get sent to the primary care physician? Is that automated or is that manual? Is it incumbent on the employee to take that to their provider? Are they able to integrate with on-site services and so forth that you might have? And is there a referral mechanism for all those people that might not have a primary care physician and need one, to help facilitate that process? And then, of course, the patient experience, key questions that you want to ask there. So how do services come to people? You can subscribe through a variety of channels. Frequently, it's through the employer, a direct-to-employer contract between the telemedicine firm and the employer. Often comes to us through the health plan as an ancillary add-on services that's provided there. Can certainly come through the on-site or near-site clinic vehicle, and there are subscriptions direct-to-consumer where people can just buy and have access that way. The pricing models vary a little bit. The most common or traditional model we see is really a per employee per month sort of an enrollment ongoing fee, and then a per use consult fee that's tacked onto that. There are some models that don't have the front-end PEPM fee, and it's just a per use fee. And then there are some that are kind of an all-inclusive subscription fee, so you're going to pay a higher per member per month rate, but all of your consultations are going to be included. Special note with that, you have to be careful if you've got consumer-driven plans with HSA accounts. You really can't provide that first dollar coverage until the deductible is met, so you need to pay attention there. So how do you decide, should I go direct to a telemedicine company, or should I take the solution that's offered through my carrier? I think we have the same goals, whichever avenue you go through. We want better outcomes, cost savings, and improved experience for the members. It's really just a good idea to line up side by side. What is the service mix you get if you go with a direct contract, and what is the level of services that are available through the carrier model? Oftentimes, not always, but frequently we see that the carrier model is not as comprehensive in nature, and is maybe a streamlined or stripped down a little bit version of the service mix. You might have limited ways to engage and have to only go through, say the carrier website for access versus a lot of other opportunities. Customer service can potentially be a little problematic. You might be dealing with multiple layers of customer service, both the carrier and the telemedicine vendor, for example, instead of just one point of contact. So you just want to ensure, do we have the full range of clinical services that are truly being provided? Do we have the same accessibility and availability in terms of time? And with a direct model, if you need to do some customization, you have more opportunity for a custom plan design or special pricing and promotional opportunities. So those are just some things to keep in mind. With regard to compliance issues, I mentioned health savings accounts. People who receive care at less than fair market value is problematic here. You can't really do that with a health savings account. So there are some exceptions for some of the preventive care services we've talked to, or some things that might be tied to an EAP or on-site clinic, but you really do need to carefully review the scope of services. We have a whole speaker on legal things, so I'm not going to go into a whole lot of detail here, but just wanted to mention you really need to pay particular attention if you have health savings accounts in place. If you're not currently offering, certainly explore the feasibility and potential impact. If you are offering telemedicine services, again, making sure that your provider is compliant with all the various state legislation. More and more, some of those barriers are coming down, and we see that improving, but it is regulated on a state-by-state basis. So if you have a population that's dispersed, you might, have limitations in what you can even offer at different locations based on some of those laws. And you have to charge fair market value if you do have the high deductible consumer-driven plans. So keeping that in mind. Mental health parity is another key issue. I'll tell you, lately I've been going through some training about mental health parity audits, and this is more complex than I could have ever dreamed in my wildest dreams when you get down to brass tacks about what you have to look at here. So parity rules do require updated testing anytime you have a change in plan design. So when you put telemedicine in, you're going to have to look at that. You're going to have to look at quantitative treatment limits, non-quantitative treatment limits. You have to see, is the copay in alignment with the medical care copay, or are you going to assess it on a separate tier of coverage? Again, extra scrutiny is needed. You might be able to use it as a separate network tier that might help you pass parity testing, and perhaps not. So you really do have to do a thorough review, and I'll let it go at that for right now. So engagement. How do you get people to use the service? These are a few tips we've picked up from our clients that have more successful utilization as a result of their program. The plan design really does matter. You want to look at that copay amount, and you want to make sure that you aren't having a barrier that, PCP visits are cheaper than using the telemedicine. That's going to be a barrier to people adopting it. To the extent that you can subsidize part or all of that copay, you'll see your utilization go up. Communication is critically important. We do have one client, I have a very specific example, that kept the same telemedicine provider but moved from a carrier-based solution to a direct contract with the telemedicine, the same provider, and saw their utilization go up threefold. Why did that happen? The only explanation that the vendor could give us is the service level agreements and the direct contract required the employer to do some regular communication about the benefit to their people, threefold increase in utilization. So, something to keep in mind. Many of them do offer very comprehensive rollout campaigns, welcome kits, ongoing, reminders. Take advantage and use those things. Plan sponsor engagement. So what are all your opportunities for integration with other services, and how can you get those cross-referral mechanisms in place? And then access. Again, I mentioned earlier, you want to incent people to get registered and to fill out that medical history before they need the service. So if you can incent that in some of your wellness program designs, or, if you have a digital navigator, if you've adopted that sort of hub and spoke sort of a model, having push messaging that reminds people or rewarding them for, going through single sign-on and getting connected. Those are all good things, and I'm sure you'll hear more exciting ideas from our later speaker. So let's talk a little bit then about on-site clinics. As I mentioned, I had two providers who were able to share some specifics, but in general, what we need to know is we're really early on in this movement to connect with on-site clinics. There's a lot of variation that still exists in these services. With the rise of the patient-centered medical home, it really does sort of raise the need for this 24/7 coverage. We see lots of variations of how this integrates with on-site clinics. In some cases, it's just an after-hours wrap for services during hours that the clinic is not open. For some employers, it's the way to offer a virtual service in lieu of the brick and mortar when they don't have a large enough population at a particular location to support that. We've got people that just simply prefer the virtual consult versus the in-person. You can have provider-to-provider consultation while you've got somebody in the on-site clinic. They might, dial in a specialist for a consult situation. So true integration here, what I've heard from all of the players, is a work in progress, varying degrees of success, but progress being made nonetheless. So the first vendor that shared some results is QuadMed, and this is an actual QuadMed client. They have multiple on-site and near-site health service centers across the country. They've got a dispersed population. They have quite a wide scope of services through the on-site clinic, primary and acute care, occupational health, wellness, lifestyle, disease management, et cetera. So their challenge was, how do we reach all these people that are in remote locations? We need a solution for after hours, and we really have high ER utilization in pockets that they were trying to address. So they partnered with a telemedicine vendor to really give 24/7 access to primary care. They integrated the health information into their own electronic medical record. And I'm told that there's a recent even upgrade to this. So previously, they had to kind of scan the electronic or the record from the virtual visit into the EMR, and it was a manual process. And now, as of 1/1, This has become an automated process, so the EMR at the telemedicine vendor has an auto alert that will directly send that to the patient's EMR at the on-site clinic, kind of behind the scenes in an automated fashion. It just kicked off on one, told so far so good, but they don't have any really longitudinal data to share about it yet. They've achieved thus far 5.2% utilization, and you can kind of see the breakout here of age group. Seems like all ages are using it. Their savings for year one of this program was estimated to be $250,000. This was achieved primarily by diversion of care from these other sources. So they asked people at the end of the visit, if you didn't have this, what would you have done? And you can see, you know, there's that factor of 12% that wouldn't have done anything. So you've got to kind of take that out of the equation. But many people would have gone to urgent care. Some would have gone to the emergency room, or just even to a primary care visit, which would have likely cost more. So their net savings were $250,000. They said that patient satisfaction, end user satisfaction is very high. From the employer perspective, they're just focused on increasing driving utilization to higher numbers. So far, so good. Second example comes to us from One Medical. Are you all familiar with One Medical as a practice model? Have a little bit of information here. So One Medical is a quickly growing primary care practice model. They started out with primary care clinics out in the community, kind of a concierge model where patients, paid to get a membership to be able to access primary care physicians at these facilities. It became so popular that employers eventually approached One Medical and said, we want to contract your services directly, and we want to integrate you into our on-site clinic operations. And so that was, a later build out. So today, they have 55 of these community-based offices in 8 different cities in the country that you can see on the map, and they've got 14 on-site employer clinics. A kind of a hip and medical, or hip and funky new look to medical care. This is like a picture from one of their community clinics. They tell me that their on-site clinics at employers look very much the same, so that doesn't look like your standard medical clinic that we walk into, I don't think. Here's what they outlined as their keys to really driving high virtual care utilization in the on-site employer clinics that they have. They create all of their technology in-house, and so they've created their own electronic medical record, and they said that that's really key, and you'll see a diagram in a minute that shows what that looks like. But the data from any kind of service, whether they see somebody in person or virtual, constantly updates that record and provides continuity of care. They said there's synergy with them being a name brand in the communities where they do function. So this poster that you see kind of at the bottom of the slide there, that's in Times Square. So it's good brand recognition that employees see it out in the community, and so when it's offered at the employer, they connect the dots and say, oh, I know what that is. They do a lot of communication and provider education as well. So this is what the ecosystem looks like. As I mentioned, the electronic medical record is at the center, so any encounter is recorded there for continuity of care. They schedule longer appointment times with their physicians in their clinics. They're 20, 30, or 45 minutes long as opposed to what the 9 minutes or 7 minutes usually get. And as part of that on-site visit, so whenever somebody comes into the clinic to see a provider, there's always an element of education about the appropriate use of the virtual service that's connected, so when and how you might want to use this when you need care. So it's kind of built into the delivery of service, which they feel like increases their utilization. The services that they offer look very much like any telemedicine service, as we've looked at before. Video, phone, secure messaging. They do dermatology consults, a lot of your common complaints and prescription refills, etc. They believe very strongly as well in the importance of communication and a customized launch campaign, and they said when they do it, they've got 7 times more employee activation and use of the service than when they don't do their full rollout campaign. So they did share results of one case study that involves actually 2 different employers with 10,000 employees in 2 different cities, New York and LA. And it's a mixed population, so there's both a blue-collar kind of worker population as well as a high-tech combined together in this study. So we've got a good, representation of the population. So you can see the eligible employees and how many office visits, 16,000 office visits in a year for the 10,000 employees. Pretty remarkable that there's over 4,000 virtual visits. A higher percentage than what we might expect, and I think a lot of it has to do with that comprehensive communication and the ongoing education by the providers. I was a little bit surprised when I first saw this chart about utilization. I would have anticipated seeing high utilization on weekends, when the on-site clinic might not be open or people have a need to have access to care. And what was shared with me is the hypotheses. They're not sure, but on the weekend, a lot of us have a tendency to say, I'm just going to grin and bear it, and get through this because I've got the weekend going on. I've got family things, I've got commitments, and I'm trying to get through it. And by the time Monday morning rolls around and you go back to the office, you realize, gosh, I'm pretty sick. I really better get this taken care of. So you kind of see the spike of the Monday utilization. So they can't really prove that out, but that was the hypotheses. Good split in the kinds of services. You see a lot of email, secure messaging, even care here. Mobile video, and then, certainly a lot of telephone. They're very pleased with the results that they've gotten. They've got excellent patient feedback. You can see these are actual testimonials from those that have used the services. And so they're excited about the possibilities in expanding to more and more employer clinics and building out this model. So I guess to wrap up my piece here, I think telemedicine does deserve serious consideration. It's a great adjunct to your benefit program, for that wraparound care to increase access to people that might be traveling or geographically dispersed where they don't have the same sort of access. There are continuous rapid advancements in the technology that support these services, so keep your eye on that. It's hard to keep up. I would say not all telemedicine services are created equal. It's not something to just flip the switch and say you've got it and think that you have a top-notch program. You really do want to look under the hood, make sure that you're looking at the full compendium of services and what kind of feedback and reporting that you'll get as a result. And I would just encourage us to keep the dialogue going. So thank you.
Well, that was wonderful, Jill. Thank you. So let's take some questions from the audience, and please stay there, if you would. Let me just kind of start out. I have a whole bunch. Is there anything that compares face-to-face telemedicine versus on the phone or email as far as effectiveness goes?
That's a great question, Larry. I can't think of any particular study that I've seen that directly did that.
Anybody in the audience familiar? Liz, are you familiar with anything like that? No? Okay.
Let's put that on the list to be done, though.
We do know that in counseling that people prefer talking to someone face-to-face rather than, or...
Some people do. Some people don't.
But we think it's more effective face-to-face generally than over the phone coaching things. So I'm just curious about that.
Actually, Larry, also one thing in sort of the behavioral health, as we're launching behavioral health and you're looking at some of the data around that, we're actually finding there's some cohorts, like younger kids, that actually react better to sort of a mobile app and mobile interaction. And so we don't know yet. There's certain aspects of telemedicine that can apply, I guess is what I'd say. Paul, did you want to add anything?
No.
Okay, thanks.
No, I think it makes sense. Having that anonymous ability so someone doesn't recognize you, but one of the tie into that is, do you find people doing it at work? Do employers say you can do this anytime? Or do you find people at the desk or in their cube kind of turning on their phone and talking to the doctor? I mean, what's the experience, or what should employers do?
I only have hearsay to share about that. I don't have a study. We do have people encourage use at work. I think people generally, if they don't have a private office, will go to a conference room. Oftentimes there's one designated conference room for things like this that people can go and shut the door and have a private conversation. I don't anticipate we see too many people sitting in their cubicle doing this in the open. I suppose some people really don't care and they might be doing that, but yeah, I mean, part of the appeal of this is it can keep somebody at work and not have to leave work. They might just need a script refilled for their child who's in daycare, but to have to, not go to the office and just get that done via phone call, it's a nice service for that.
Okay. I get a question. Please, go ahead.
You mentioned, do you introduction here or no? Just question. Okay, Larry, never mind. I'll fire away.
You have a question?
I do have a question, not just an introduction. You mentioned a lot about direct to the vendor and then also sourcing telemedicine through the health plan. Are you seeing any cases, and maybe this is outside of the employer's purview, but where providers, whether it's in an employer-led ACO or just a regular provider setting, are doing telemedicine without the involvement of the health plan or the employer?
I personally have not. I'm sure it probably is occurring. I haven't had that experience. And I don't think it's something we've collected data on that I can tell.
I just would say I think that's as providers and plans start to get together, which is definitely a macro trend, that I think providers will start to do this from a convenience perspective and an efficiency perspective, even especially as coding allows for proper reimbursement at that level. So it's an interesting question in my mind of whether, over the long term, whether employers have to purchase telemedicine directly or it actually comes to them as part of their, kind of provider contracts that are provided through the plan.
I will say in the one medical example that we just saw, they indicated they do not charge extra for telemedicine services. It just comes as part of the service package with the primary care services. So to your point, yeah, I guess it is happening.
Stephanie?
I also wanted to mention it's really easy to think about the office-based environment, but we have a number of clients where, when we get back to the question around in the workplace versus at home and at night, right? When we have several retail clients who see a tremendous amount of at-work utilization, because for them it's you have hourly employees, you have folks that it is really money out of their pocket, not just inconvenience.
Sure.
So they tend to, that's where we see either people who are working remotely or in sort of more retail settings, we see a lot more opportunity for people to use it during the workplace.
Let me also ask you mentioned that employers could support the cost for employees by contributing or subsidizing a portion of that, but you said not for high deductible plans. But as long as high deductible enrollees have some payment with fair market value, an employer could still subsidize it, but as long as they're still paying out of their pocket, wouldn't that be
correct?
compliant?
Yeah, as long as they're making a fair market value payment for the service, it should be okay.
Yeah, and for those not familiar with fair market value, the IRS does not define that, and so employers just have to have some rationale and understanding for deciding what that is. But for employers, for example, with on-site clinics, we know the survey we've done shows that employers charge as little as $10 versus the Medicare rate for a physician visit. And so far they haven't been challenged yet. So it's interesting. The other thing is that if telemedicine was for a preventive service, then would it be free?
It could be.
Could be?
Yeah, when it's an accepted service, yeah. In limited conditions, but you do want a legal review before you make that decision on your own. That would be my advice.
Okay. Laura, any questions online? Okay.
The other thing I would say with regard to the parity issue, and I'm not sure if I mentioned this or not, I apologize if it's repeat. People have asked us the question, some of our clients have had their own legal counsel give the advice that you cannot simply put in medical telemedicine services without adding the behavioral health component and be in compliance with parity now that behavioral health services are available. I spoke with our own attorneys about it, and they said, it's a dicey situation right now. They said the regulators have not ruled or taken it on really, and we have no case law in the courts yet to determine that because behavioral health is kind of early on in the service offering, you could potentially make the case that, it's not well enough developed or studied to prove the efficacy yet. That might get you out. But more and more, I think the prevailing thought process is if you're offering medical service, it behooves you to add the behavioral health, as a protection, because it's seen as a good thing.
Okay. There's been some talk about induced demand with telemedicine, that people wouldn't have gotten the service if it wasn't on their phone immediately available. Is that generating a necessary cost, or is that not that significant?
Interesting question. Again, I don't think I have any hard data that I can speak to about that. I would maybe ask some of the vendors in the audience if they've seen that sort of proliferation of induced demand. There's potential. I think people more so that need service that haven't had any service, it's necessarily not a bad thing that they haven't encountered once in a while with the healthcare system. You can find out all kinds of things, but I don't have a statistic to support it.
Paul?
I would say that, well, we're monitoring this stuff very closely. I'm not going to pretend that we're not getting a hangnail or two for a telemedicine visit, but we're very closely monitoring use versus need. And yes, you're going to find a fringe periphery of probably unnecessary care, but it's a fraction.
Not something to worry about then.
Right.
Okay.
Yeah.
And you're not spending $300 a visit either, so.
Sure, okay.
One of the things I didn't hear you mention when you compare direct contracting with a telemedicine provider versus through the health plan is the difference perhaps in reporting capabilities.
Yes.
You could comment more on that. What might be better or worse?
Yeah, the likelihood is high that with a direct contract, you're going to get much more detailed and comprehensive reporting, and you'd have the ability to customize some of that reporting to your needs versus with the carrier, you're probably going to get a very standard report. Yeah.
Let me ask
Thank
a
you for
final
bringing that
question.
up. It's a good differentiator.
Let me ask a final question. So you talked about the kiosk and the problem people have had with kiosks, but you know some of the more effective telemedicine is when you're able to take vital signs and there's a physician on the other side, particularly in remote locations. Does it make sense, or are there more entities where you have a nurse or someone with the patient helping them gather that vital signs and then connecting with the physician, or is it pretty much self-service?
I think for the most part it's self-service unless it's integrated into an on-site clinic environment where you might have providers available to do that. Yeah.
Because I'm wondering if, you know, would it help to have a local person coaching once the TV is off, the video is off, and you're not talking to the doctor anymore?
Certainly it would be helpful, yeah.
Something different.
Yeah.
Okay. Any other questions for Cheryl? Please, thanks, Cheryl. Thank you very much.
You're very welcome. Thank you.
Oh, one more. Go ahead.
Sorry. Oh, Paul, come
Oh,
on.
I'm sorry.
So we always want to make sure that we're in tune with where you're thinking and leaning in the future. So when you think of, okay, behavioral health is the latest frontier for telemed, any pontifications on where Mercer sees the next area of focus that vendors like ourselves should be thinking about?
My comment would be the build-out of integration with on-site clinics and other services would be the next focal area. Yeah. It's already started, but I think it needs more attention.
Great. Thanks again, Cheryl.
Thank you.
It's been great. Thank you. So Cheryl covered a lot of territory that really gives us a good foundation to work through the rest of our day. What we want to do now is to give you the key concerns or challenges on a regulatory and legal basis that you have to look at if you're going to move forward with telemedicine. And so we've invited Allison Wills, Executive Director of State Programs and Senior Director of Health Policy for ERIC, the ERISA Industry Committee, to join us today to talk about this. Allie has been involved with ERIC's state mandate program and ERIC's telemedicine task force. She is the key person for that organization, which she'll talk about, but generally represents the jumbo employers in our country. She also monitors other state and federal activities impacting health benefits. Prior to joining ERIC, she specialized in health policy reform and implementation efforts at the National Academy of State Health Policy, focusing primarily on insurance exchanges. Please welcome Allison Wills. Also, I did want to remind you, if you want to see the materials, on the agenda in the upper right corner is a link, and if you go to that link, you can download all the presentations that are here.
Well, thank you, Larry, for having me here today, and thank you to the MBGH. At ERIC, we're always excited when we have the opportunity to partner with this organization. As you'll soon find out, Larry and MBGH and I, we share a lot of overlapping members. So I think we share the perspective on telemedicine and would like to increase access. And building on Cheryl's really excellent primer on what telemedicine is and where the opportunities lie, I am going to try and keep this optimistic with a pep in my step because it's early morning, but we're talking about legal and regulatory challenges and what we're doing to try and combat those so that you can really fully explore all of the opportunities at the state and federal level when you're an employer trying to offer these services. So just to start, as a little bit of background on what the ERISA Industry Committee, or ERIC, is. in a very DC fashion, we are an acronym on an acronym. So when I say ERIC, I'm not talking about a person. I'm talking about a collection of employer members who our minimum is about 10,000 employees, and they're all multi-state employers. So we have a pretty unique perspective. We cut across industry, but we only speak to those employers' employee benefits interests. So we focus primarily on health and retirement and compensation issues, and we advocate. So that's where we draw our nice partnership with NBGH and like-minded organizations that represent similar employers. We're active in DC at the federal level, and then as Larry mentioned with the State Mandated Action Program and our telehealth initiative, we actually go state by state to advocate for regulatory and legal changes to make sure that employers have the ability to offer the services they would like to. And just a little bit more on our telehealth initiative specifically. So in 2015, our CEO went to our board and said, what's the new hot issue for you, about 100 of America's largest employers? What do you want to be able to offer that you're not able to do right now? Where can we jump in? And they said, you know what, it's telehealth. We want to be able to utilize telehealth. We want to offer it to our employees, and we're really hitting a lot of problems at the state level because we're seeing a patchwork of laws and regulations that make it pretty difficult for us as employers to offer uniform benefits to our employees regardless of where they live and work. And that's a problem when you have 100,000 employees spread across the country, sometimes in every zip code. It's difficult to comply with a myriad of disparate rules and regulations. And so that's why the ERIC Telehealth Initiative was born and why I was brought on to ERIC to help lead the charge so that we could drill down into what the issues were, where the hang-ups were, and really start to educate policymakers on what the multi-employer or multi-state employer perspective really is and why it matters on this issue. So for the agenda today and what I'm going to run through, I'm going to start with a deep dive into what the issues are. So that will take probably the majority of my time. It's about 10 slides, 10 different issues that we see thematically at the state legislative and regulatory level that can create problems for our employers when you're trying to define how you want to offer a telemedicine solution to your employees. Then I'll talk a little bit about Illinois. I will give my caveat that I can't give legal advice on what you can do in the state of Illinois, but I will try to give you a primer in terms of questions to ask, and I did include code for any lawyers in the room or online who want to know where to look. You can see what Illinois has to offer right now. And then I follow up with a little bit on on-site clinics in terms of utilizing telemedicine, integrating telemedicine services into your on-site clinics, maybe some questions that you should start asking. So with that, a deep dive into our common issues. And with this, please feel free to ask questions throughout the presentation. I'll do my best to pivot and answer if you have a particular interest, and I'll leave time at the end for any questions as well. So the first, with defining telemedicine and telehealth, you would think this would be simple. I can assure you that it is not. Defining telemedicine, we have a pretty common understanding of vaguely what it is. And as Cheryl described aptly, it can take a lot of different forms. It can include a lot of different things. It can be remote patient monitoring. It can be store and forward. It can be audiovisual communication, or use a variety of other technology platforms to have a provider in one location connect with an individual in a different location. What we see when defining telemedicine and telehealth for the purposes of state legislation, or for that matter, federal legislation, regulators, lawmakers like to embed a lot of restrictions in the actual definition itself. So that's the first place to look. If you're looking at legislation or you're trying to get guidance on where might this limitation on what I want to offer pop up, the first place is the definition of telemedicine. Because if they don't say something broadly, like this is the general concept of connecting an individual in one location with a provider in another location, then you're going to start getting restrictions in terms of the type of technology you can use to provide, whether it has to be audio-visual, whether it has to be, whether there's only speaking to store and forward, which is, taking a picture and sending it at a different time, whether it has to happen at the same time, which refers to anytime you see the terms synchronous or asynchronous in the telehealth definition, that should be an alert for you to pay attention, because what they're doing right there is limiting the market access for you to choose what kind of telemedicine you want to provide. Because that means, does it have to be real time or does it not have to be real time? And they do this all in the very definition of telemedicine and telehealth. I will say there are some states that shall remain nameless who have gotten my particular ire because they decide to define telemedicine and telehealth, and they do it in different ways. And then they choose to subcategorize all of their references on a case-by-case basis, further creating a patchwork effect in their own legislation in one state. So please be privy to defining telemedicine and telehealth and how you talk about it. For the purposes of my presentation, I use the terms interchangeably on purpose because I'm not speaking about one piece of legislation or one law. I also use telehealth generally just because it tends to be slightly more broad if you look at the definitions. In terms of Eric's position, and when I say Eric's position, I'm saying these are principles that we've developed in collaboration with large employers, hearing from them about what they would like to see and how to create access at the state level. They very much like to see telehealth and telemedicine defined broadly, not in different ways in the same law, and should be inclusive of all types of care that use different types of technology that connect a provider in one location with a patient in another location. We don't want to see limitations at this point because this is the starting game. You know, this is the base level framework. We don't want to be restricted by a state mandate or a federal mandate. And just for those of you who are interested in the federal laws, I will give a quick shout out to the own federal patchwork, which there's 6 definitions of telemedicine, even though it's not popular yet at the federal level, in state regulations. So there's no shortage of examples to review if you'd like to do so. Moving on to the next issue, and these are all critically important, so I just decided to put them in no particular order in terms of relevance or significance in terms of how it can limit access to telemedicine services, but establishing a patient-provider relationship. And on this note, this speaks really to why this is a state issue in large part. Patient-provider relationships are defined in large part by state regulatory boards that regulate providers, so they license the providers. And because they can flex their muscle in terms of what jurisdiction a provider has, in terms of their license, this is a place to watch out for because even if something is not in the law, a state regulatory board can adopt a rule that limits the ability of a provider to act in a certain way. And as all of you know, I'm sure are aware, there are multiple state regulatory boards. So nurses are often separate from doctors, or separate from psychiatrists, or separate from what have you. And so each one of those boards in a state can actually adopt a different definition of a permissible way to create a patient-provider relationship. So if you haven't heard it yet, there's a multiplier effect here that is significant, and there's a lot of issues for downfall, which is why we're actively trying to monitor and weigh in the states to streamline this. But if you say, I'll get to this a little bit later, but a little preview, want to offer services at an on-site clinic and you don't want to be restricted to using a certain type of provider, you will need to pay attention to the telemedicine rules that pertain to all different types of providers so that you can contract at will with the providers you'd like to have at your on-site clinic without having different requirements pertain to each different provider on that on-site clinic, because it could potentially be different with telemedicine because of the state regulatory boards. So I'm looking at everybody's faces this morning. I feel like I'm aptly scaring everybody. It's a little early for that, so I apologize. I will say that we are getting some positive response in terms of education once folks realize this multiplier effect and what they're doing to impinge access to care, which that is a point that speaks to the regulatory boards. And I write a lot of letters to regulatory boards during rulemaking comments, and they all have some mission that says, our purpose for existing is to maintain a high standard of care for whatever services are provided, to regulate the industry, whether that be nursing or doctors providing services, and we want to ensure the health, welfare, and safety of the folks in our state. And so we use that messaging to say, yes, and based on that very reason, you need to listen to us and not restrict access to care for the folks in your state. They have been receptive to that, and we have seen progress, but it is an ongoing battle. And our letters are public, and all this information is public. If you want to talk to your state regulatory boards, I encourage you to do so. They are receptive because they just don't always realize the negative impact they're having because they're not looking at what the next board over is doing, even if it's in the same state. There is no requirement to collaborate between boards. And I say that full disclosure, I used to represent regulatory boards in the state, all very nice people, but they don't have that perspective. And so it requires that conversation to make sure that they're not inadvertently limiting employers' ability to offer this service to folks. I've gone well off my slide. Luckily, you can get the base here in terms of what patient-provider relationships. States take different approaches to this as well. So, and it's very reflective of state attitudes about how they feel about telemedicine in general. I will say, I don't think it's any surprise. Anybody who follows the news in telemedicine will know there are different camps of thought about telemedicine in state. You can often see a conflict between a medical society perhaps, and telehealth providers and employers and other folks. We all come to the table and try to work through the issues, but the legislative and lawmakers' appetite for where they want to fall on the spectrum can sometimes be very influenced by powerful lobbies in the state. And so we're trying to go ahead and work with everybody who comes to the table, again, to make sure that we're not limited on establishing a patient-provider relationship and that other requirements aren't tacked on. Like, you shouldn't have to go see a person and establish a patient-provider relationship by visiting a provider at their doctor's office before you can ever think about using telemedicine. That is a proposal that has been litigated in some states. So we're trying to dissuade that sort of activity. But I will say there's also other requirements. Some states' regulatory boards have tried to put a mandate saying that if you use telemedicine services, you must have an in-person follow-up visit within a certain amount of time. And if you just think that through, it doesn't really make sense. You can't, that's overly prescriptive for a provider. It takes away the provider's discretion to say, I don't know what I'm going to talk to you if you come into my office in 6 weeks about, because we've already addressed the issue and solved it. And so going to points of, increased utilization that's not necessary, some legislatures or rulemaking bodies are trying to tack those things on, which really just takes away some of the cost effectiveness of telemedicine, and it's nonsensical, to be fair. My views are clear. Again, and Eric's position, as you can tell, is that telehealth laws and regulations should be adopted that allow a patient-provider relationship to be established using a telemedicine service. Again, this is not the place to put a mandate on requiring and layering different requirements. We do believe that standard of care, I'll get to that in just a minute, should be maintained, but you can't prescribe that in legislation or rulemaking bodies because it's a case-by-case determination. And as my lead-in to standard of care, this is a particularly important issue, and it's something that as telehealth becomes more common, in terms of folks knowing what telemedicine is, knowing that they have telehealth services that they can tap into. There's a lot of talk about, okay, well, what is the standard of care? If I go have a telemedicine visit, is it the same thing as visiting somebody in person? And what we say is it depends. It depends on what's required by the visit, but you should trust the providers to use their expertise on a case-by-case basis to determine what is required. They have a responsibility, they've taken an oath to do that. It is a requirement of their license, and all of these providers are licensed in their states. So we say defer to that, to the existing framework, to maintain a high standard of care. And again, I already said I used to represent regulatory boards, including medical and nursing boards, and they take this role seriously. If they start to see a deviation in the level of activity, there are existing mechanisms in place to make sure that providers don't abuse the structure. And so our argument here is you don't have to reinvent the wheel. The infrastructure already exists from a regulatory perspective to make sure that you're maintaining a standard of care that is a high quality, and that telemedicine is really just another mode of delivering care. It is appropriate in some circumstances, it is not appropriate in other circumstances, and the provider has the responsibility as a provider to a patient that they determine which is required in which scenario, and then to make sure that they comply. And so that's our messaging, and that is something that we feel very strongly about, Eric. again, when we're talking to folks, as the employer community, we don't want to in any way denigrate the standard of care that our employees are getting. The whole purpose of offering health care benefits to employees is to make sure that you have a happy and healthy workforce. We don't want lackluster care. We don't want to sacrifice high-quality care for our employees. We want access to high-quality care that, again, going back to Cheryl's points, can reduce absenteeism, increase the level of happiness for our employees, and the overall health and well-being of folks. And so in order to do that, this is all consistent. Just maintain the standard of care. And this is another very important point, as you could tell as I jumped down the rabbit hole a little bit with the regulatory framework as it currently exists. It's just an educational point. You don't necessarily need something completely new to make sure that this standard is met. And there's a little bit of fear, I think, from rule makers, from policymakers at the state level, that telemedicine is new. And they want to make sure that they're doing their job to protect folks. And they don't totally know what is required to do that. And so when we have this conversation with them, we say, don't worry. You already have the structure in place. So just have the conversations on a case-by-case basis, and we'll get there together. So the next issue that I have is interstate practice of providers. And this is significant for ERIC members and for MBGH members that are multi-state because of the placement of your employees around the country. And this also has to go to access to telehealth services in terms of where your providers are able to engage with patients. And this is a particularly important, going back to the startling statistic about psychiatrists. I keep referencing your presentation. It was really great. It is, if you are in a rural or remote location or even an urban underserved community and you need a psychiatrist for a particular care setting, having access to an in-state provider might be necessary, and we don't want to see limited access to care because there are roadblocks along the way for different sorts of providers. I will say that in terms of provider groups, and when I say that I mean doctors or nurses or psychiatrists, have all taken very different approaches to their concept of interstate practice. And they're currently looking at different sort of compact models, which means that each state has their regulatory board, but to a certain extent, and it differs depending on which type of provider you are, you can work across state lines because they make it a little bit easier to get your license activated in a neighboring state or in a different state. And that just increases the mobility of providers to make sure that they're complying with the different rules and regulations. I will say for any folks who work with the providers themselves, this is a particularly important issue because depending on where the practice of medicine, how that's determined, whether it's the location of the provider or the location of the patient, and that can differ sometimes on specific rules or legislation or laws, you need to pay attention to that because the provider might be stepping into an arena where if they're licensed in California and Oregon but not Washington, depending on how things are defined, they could be tripping into another state not realizing it, which exposes the provider to liability, potentially other people to liability, and so it's just something to pay attention to. And so in order to get ahead of this issue a little bit, we encourage the interstate practice of providers at ERIC, just because we don't want limitations on care. And I will say we have stopped short of endorsing those particular compacts because we're provider neutral too. We also want to make sure that there's equal access to the providers that you would like to use, whether that be in your on-site clinic or just that you would like to contract through these various mechanisms. So we just want to make sure that we're doing what we can to make it easier. And yeah.
I'm pretty loud. I'm pretty loud.
So I understand the interstate practice for providers, but what about services? I know when telemedicine first launched, maybe 3 years ago, it was about services, prescribing drugs, which you couldn't do in certain states. So you were able to use the service, but to get better, they weren't allowed to prescribe you drugs.
And that depends on the state law. It also depends on the state pharmacy board. And it depends on the e-prescribing laws. And this is something, and it also depends on education. There's some confusion in different states because if a provider thinks that they might be tripping liability, they are going to be conservative and not fill a prescription. We have heard about that in some states. So now we're actually seeing a legislative push to provide clarity around this so that providers, aren't chilled from acting because they don't want to assume liability for doing something that could threaten their license if they're unclear. So that's a part of the problem. Then it's also what pharmacies are doing in terms of what kind of prescriptions they'll allow and what can be filled. Then a layer on top of that is there are limitations on prescribing in terms of controlled substances and classes. And so sometimes you can fill one prescription, but you cannot fill another prescription. More of the multiplier effect, I'm sorry. but we are working on it. It is another issue that we're addressing because an interesting point on prescribing, and Cheryl spoke to this a bit, is just that satisfaction with your telehealth appointment relies heavily on your ability to have a full service appointment, which includes getting a prescription if it's needed. And then, of course, being able to fill that prescription, so it's not just a piece of paper, and so that you can solve your problem. So, yes, it continues to be an issue. It is becoming less of an issue as we get ahead of the topic, and there have been some very strong pushes, for example, in states like New Jersey, where folks have had this problem, and were able to quickly address it through clarification and education. That's the best case scenario. Legislation is underway right now, including some language, for example, in Kansas right now. So it continues, but we're trying to get the level setting to make sure that people understand what's appropriate in this space. But yes, thank you. And it's foreshadowing for another topic too. So I'll go quickly through the rest of these. Originating site requirements, this is just something that I wanted everybody to be aware of as a matter of due diligence. So originating site requirements, I'm happy to say, are sort of going the way of the dodo, which is a very good thing. Originating site requirements mean exactly what they say, which is that you have to be in a specific location, whether that be geographic or rural, or meet certain requirements in order to be able to use a telemedicine service and have that service be considered reimbursable. This is a framework that you often see in, well, it is required in Medicare. You often see the copycat language in state Medicaid language. Not that those are sort of independent populations of the employer-sponsored community, but it was something that we disliked so much that we wanted to be proactive and make sure it didn't get in our way. And so it is something that you will sometimes see different advocacy groups push if they want to protect a market, is my perspective. For example, if you have to be at a clinic somewhere to access a service, or a hospital system to access a service, that is sometimes a requirement that we'll see. And so we, again, try to advocate against those. It's at your discretion if you would like to require, employees to go to a specific location. It's not something that we want to see in legislation or rulemaking, just again because it limits your ability and limits your flexibility. So just a quick note on originating sites. If you see the term too, you don't have to be worried about this every time you see it. A lot of legislation will say an originating site is for the purposes of definition, but doesn't actually limit it. So it's just something to pay attention to, but it doesn't always have to be an alarming situation. Sometimes folks just use it for the purposes of defining what telemedicine is. And on the next point is just coordination between providers. This is something that was sort of a later add to Eric's positions, and this is because we've heard it from our employees, actually as recently as our board meeting this year, that this is something that they've heard a lot from their medical clinics, from their medical directors, from others. They want to encourage coordination between providers just so that there's no dropped information, and so that they make sure that folks are getting full care services in terms of providers talking to each other, and at least that they have access to the information so they can treat patients as they need to and have all the information that they need. This is not something that we're not advocating for a mandate here. We're just advocating for coordination to be encouraged so that there's information sharing and utilization of different platforms. And this just reflects the current conversation, I think, more broadly in healthcare about how coordination of healthcare services is generally a good thing for patients. So the other aspect of this particular conversation is this is a way to compromise with other folks at the table who are working through legislative language. Once they hear that we're not trying to cut anybody out or have kind of a discombobulated service setting for patients, I think it alleviates some of the fear for certain medical provider groups. So and this is something that I think you will continue to hear more about as you see just different legislation proposed and different rules. And finally, informed consent is an important issue. This is not something that for Eric was originally part of our structure or advocacy platform, but it is something that we decided, okay, it's in so many pieces of legislation and it's out there, it's a thing that we should address that it exists and how we expect telemedicine to tie into it. This is another place where you sometimes will see the attitudes of the state legislature or rulemaking bodies reflected. If they start layering on a lot of informed consent requirements, for example, you need a written agreement with the patient before you can use telemedicine service. That's a pretty clear block to utilizing telehealth, and so we don't want to see that. We do advocate for just complying with existing informed consent requirements. Just means for the purposes of a provider speaking with a patient that they have, an easy conversation. And this is also highly determined on a case state-by-state basis in terms of whatever laws pertain in the state. But we don't want to see a different structure created for telemedicine that's separate from in-person care. That's why it sort of bubbled up to the top of something that we just need to address so that it's not an additional barrier on top of everything else that would impede access to telemedicine services. And I had to address reimbursement because that's a particularly important issue in the legislative and regulatory area. So, and this is something that could take up its own hour in terms of conversation. So this will be my very quick high-level primer on reimbursement issues and conflicts at the state legislative level. So there's a lot of activity on reimbursement in terms of there are some communities in this world that are pushing for what we refer to as reimbursement parity, which just means that you need the same pay between an in-person care and a telehealth visit. This is something that's been pushed now for a few years. Quite a few states have some variation of reimbursement parity. That could be coverage parity too, which requires that if you cover a service in person, you need to cover it via telemedicine too. That's a slightly different perspective than using the same rate as language that we're particularly concerned about. I'm happy to talk about this more if people have questions about reimbursement. From Eric's perspective, when there's cost savings achieved using telemedicine, we would like to see that pass through to the payer, so we do not like to see same rate as language in state legislation. Again, this is something that can be determined on contract basis and in conversations with employers and their vendors, et cetera. It's just not a mandate that we'd like to see in law. This is an ongoing conversation and I think an educational opportunity with variety of folks at the table. I personally advocate for not having reimbursement parity language because I don't think that it aligns well with our changing face of healthcare where you're looking at capitated payments and other incentive metrics. I think that it gives providers more flexibility if you don't have same rate as language for them to utilize telemedicine as they see fit in order to meet their metrics. That's by virtue of me being from Oregon, where there are a whole lot of metrics on providers that they need to be, and they need some new tools to do it in order to meet those demands. And so, again, this is something, I'm teeing it up for questions and comments if you'd like to explore it more. But this is a big issue. It is something that we feel very strongly about because we want to see the cost savings achieved through telemedicine pass through to the employer to bend the cost curve of healthcare services. And I spoke about this a little bit already, so I won't go more into the prescribing. We touched on the issue. It's important. It speaks directly to employees' satisfaction when they use telemedicine visits, which going on to the utilization point, which I know is a very critical theme in terms of driving utilization. The happier employees are with using their telemedicine visits and encounters, the more likely they'll go use it more and tell their friends to do the same. And so we are very actively addressing the prescribing issue just to make sure that we don't hit a roadblock here or just have confusion that really makes it difficult for folks to know whether or not their prescription will be filled if they use a telemedicine visit. So as I said, that was the longest portion of my presentation. that was the deep breath, so we can take a kind of sigh of relief now and focus on Illinois in particular. This is much more brief, and again, I have to do my due diligence, give my law caveat where I can't provide legal advice. This is not giving you a direction on what you should or could do, but it is telling you some laws that are on the books that you should probably look at if you're going to offer telehealth in Illinois. I encourage you to talk to your counsel, and I can tell you that there are efforts underway right now. There's actually a Telehealth Illinois Law Forum that is actually looking at different components of Illinois telehealth laws and trying to find pockets and opportunities to create a legislative solution. So if you'd like to know more about that, I can tell you about that too. But for what it's worth, here's telehealth as it's defined in Illinois. I will say that there's not comprehensive telehealth legislation in the state. There's just not. And so the definitions that apply here apply in very different ways. This does require sort of cross-reference to different codes. This is not true for all providers in all settings, but this is sort of a starting basis for at least some version of a telehealth law in Illinois that you can see something that's on the books right now. And so I will call attention to the fact that here is a perfect example of interactive telecommunication system that's restricted definition. It requires audio and visual system permitting two-way live interactive. And if you haven't read hundreds of telehealth definitions yet, like I've had the pleasure of doing, you might not immediately take pause at that. But using the word "and" there and the way the commas are here, this is actually a very restrictive definition of telemedicine because it's saying that you can't use just a phone to talk to somebody. That's not telemedicine, or that's not an interactive telecommunication system. You can't use store and forward because that doesn't happen at the same time. And so it's cutting out different ways that you can use telehealth right there, and they did it in a tricky way because they defined interactive telecommunication system, and you have to go to telehealth services to realize that they embed that definition into their telehealth services. It's very, very nicely crafted telehealth definition here. So they tried to slide it under the radar because you might not know. If you thought that you got to define interactive telecommunication system, you might think that's great because I can just say that that's a phone call or whatever else, but you would be wrong. So it's important to take these in conjunction with each other. Again, this is a starting framework. It is limiting. It's not great. So there's lots of conversations in the state going on right now to try and fix this and create a better framework. Building on that a little bit, requirements for private payers. And again, I put all of the sites in here so that you can see how these particularly are limited if you're interested in offering telemedicine services in this state right now. I'm sure your council is already well aware of these, but if you would like to do some Googling and perusing on your own time, feel free. And so this speaks to individual and group policies. Again, how you offer your plan, how your structure is defined, that will be very critically important to see how these apply to you. But there's some interesting coverage requirements. It speaks to how you cannot limit access to telemedicine here in sort of interesting ways. This, from our perspective, and I'm calling attention to the third bullet point and the sub-bullet points below it, that is actually not a problem for us. These actually create access to telemedicine services, or you would think that it would, until you go back and look at the definition and see how restricted it is. So what this is saying is that you can't sort of discriminate against telemedicine services, which from our employer's perspective is fine because they actually want to offer telehealth services. So that's fine. That's sort of a baseline telling them they can't do something that they don't want to do. So it's not a problem. But just calling attention to that. So it's very much a patchwork effect here in Illinois, and I encourage you to take a deeper dive in, to consult with your counsel to look at these particular laws. Also, stay tuned for your next legislative session. I have a feeling a bill is going to be dropped in 2018 in Illinois that will help address telehealth. So, and we can talk more about that too. Yes?
The one thing I would say about Illinois that's probably one of the most restrictive components is the requirement around a telepresenter to be present for reimbursement. So I just wanted to make sure that you didn't mention the telepresenter and what's defined as a telepresenter in the state of Illinois, but for behavioral health, that's definitely an issue.
No, it's a good point, and so we can talk about telepresenter. You're absolutely right. I didn't put it in my slides, but it's important. Telepresenter is requiring somebody, a provider, to be present at the time of a telehealth service for the purposes, usually of reimbursement is usually how they tie it in there, and it's another way to restrict access. Because if you're requiring a certain type of provider to be present with the patient, you're in effect usually requiring the patient to travel to a particular location to see that said provider, limiting the flexibility, limiting the time they can access telemedicine services. It's another very important issue. Another one, again, at Eric, we don't particularly like, that would fall into our category of other things that limit telemedicine services that should not be required. So absolutely, thank you for raising that. It is something to pay attention to. And also something I would say pay attention to for next legislative session, because it's on the docket. And again, this just speaks a little bit more to some of the patchwork of Illinois telehealth laws. Here, I just included for sort of reference purposes some of the other laws that are on the books. Again, like you can see there, the one that speaks to occupational therapists, that's clearly a more limited definition or requirement. But just, again, wanted to, since we're in Illinois, wanted to honor the state and sort of give you a scope of what is at play here today. And moving on just quickly to telehealth and on-site clinics. Here's the portion of my presentation where I ask more questions than give answers. I will be honest about that. But these are, it's starter list of things to consider when you're looking at integrating telehealth services with your on-site clinic. So from our perspective, there's a lot of opportunity here. And it's definitely something that ERIC members are interested in. It's something that if it's done thoughtfully and handled with care, that you can actually explore quite a bit in terms of the benefits that you can reap from this sort of structure. And so it's particularly important, but because of the number of different rules, regulations, laws that get pulled into this, I see an eye roll in the audience, and I think that's apt, it quickly becomes a problem. And so as with the other issues that I went over, I'll just sort of reference back to those. Those all get carried over here too, because they all still apply. So the practice of medicine is regulated at the state, so all of those provider requirements still carry over. There's no exemption for on-site clinics, so it's definitely something to pay attention to, just so that you're not stuck in a situation where you have doctors, you have nurses, you have PAs, you have NPs, and different requirements apply. So it's not something that we would wish on anybody, especially our members. And so, questions to ask, and here I will say that, pay attention to whether an in-person visit is required to establish the patient-provider relationship. Do originating site restrictions apply? I won't read through all of these. I will just note a couple that are in addition to the issues that I stated above, which are, what are the privacy laws? And what sort of is the structure that you have for protecting the information? If you have an on-site clinic, what are sort of not only your tech platforms, but just physical privacy? What sort of is your physical setup? And how is information communicated? And this is important not just for your employees' comfort, which does matter a lot. They don't want their employers to know about their healthcare data, nor do the employers want to know for that matter, but it's important. And so just pay attention to what privacy laws apply. And when I say privacy laws, I mean HIPAA, of course, but I also mean, cybersecurity requirements, other sort of lurking issues that pertain because telemedicine is a technology platform in part. So look at the combination of those. And then just on the last one is legal issues to consider. Again, who owns the data? This is slightly different. This will inform your privacy conversation on cybersecurity, but who owns that information is going to be particularly important because it's going to play into what's required from you as the employer, what's required from your vendors, what's required in the contracts that you stand up in order to make this relationship possible. Other important points are, what are you doing to steer your workers to the clinic and to telehealth? I raise this point because if you say have a wellness program and are incentivizing your employees to use care that is offered at your on-site clinic, please pay attention to all of the wellness regulations and what you can and cannot do to incentivize folks. It's a tricky world we live in. It's fun for those of us who get to look at all the laws and regulations and come up with the creative solutions, but we would hate for anybody to sort of trip one of these laws without realizing it. And, then the last one, which is an ode to our name, the ERISA Industry Committee, please pay attention to how you're offering these benefits to your employees, because if you're, depending on how you do it, if you're offering it to all of your employees, if it's an embedded benefit through your TPA or what have you, there are possibilities for you to run up against ERISA. And we would hate for folks to run into that brick wall without realizing it. So this is particularly important, say, if you're a retailer and you want to offer this health benefit to your employees who are not eligible for your health benefit plan, that is the ERISA plan. Please pay attention to how you're offering that. Please consult your counsel before you do that, because with ERISA, for those of you who aren't steeped in it every day, there are a lot of reporting requirements. There are a lot of other base requirements in what you have to offer as part of that basic health plan if, say, the Department of Labor thinks that what you're doing, in effect, is offering what should be an ERISA-covered plan by offering a telehealth service. So, again, wide eyes in the room. That was sort of the point of this, but please pay attention to that particular issue. It's something that we're engaging with rulemakers to make sure that we can protect members and make sure that everybody's fully informed about what the parameters are for offering telemedicine services to your employees. So with that, that's me, and are there any additional questions?
Questions? In the room, audience?
I'm glad you brought up that last one. I was going to bring that up anyway, because we have 80% of our employees with employer-sponsored benefits only. They're not handling part-timers on telemed, but 10 or 20% are. And it seems the trap there on the ERISA side is, okay, let's call this a health benefit, Department of Labor. Now with ERISA, I've got COBRA, so by default, I perhaps now have to do an initial notice of COBRA for part-timers just because they have telemedicine benefits, and offer them COBRA if they terminate just for a telemed benefit. And do you have a position on that?
I have lots of thoughts on that.
Thoughts, all right. I'll take thoughts. Thoughts are, difference between thoughts and positions, but thoughts would be appreciated, certainly.
So I will say it's highly, highly fact-dependent, in terms of how the employer chooses to execute their contract with the vendor, who the population is that you're offering the telemedicine services for, whether that's an add-on benefit, whether it's for the population that otherwise does not have employee benefits. The DOL is a very real enforcer of ERISA, and well beyond COBRA, there are a number of requirements that come on with an ERISA health plan. It is a very, very significant commitment and not something that somebody should do accidentally, and they also come with steep fines. So please pay attention to ERISA. Consult counsel is my big rallying cry on this for reviewing those contracts if you're going to offer this to any discrete populations that are outside of the normal benefit plan. And for that matter, consult counsel anyways if you're offering telemedicine in your normal benefit plan, but there's this particular area of risk.
Thank you. Oh, Jim.
It makes me think about bargained populations.
Yeah.
Previously at my former employer, we implemented telemedicine, but purposely did not put it into any of our bargained groups because we felt that it should be bargained in.
Mm-hmm.
Any thoughts about how we approached that?
On that particular issue, it's not something that we've fully explored in terms of the relationship with collective bargaining agreements, but it is something that for our employers, again, we encourage folks to do things on a case-by-case basis, to explore their unique populations, and I think most of them would probably, this is just me saying this without having consulted them, would approach them it in a similar way, just saying, like, let's have this conversation as an add-on. But that would be my gut instinct. I could be wrong.
Anybody else want to comment? Mike?
Is this on? So quick question about payment and reimbursement. Big movement in general towards value-based and also bundle payment. but we haven't been talking about that a lot in telemedicine because it's, largely visit-based.
Mhm.
Are you seeing any movement at the federal level or the state level towards talking about things like bundles of, all-you-can-eat telemedicine or value-based reimbursement for telemedicine that would lead to reimbursement that's not just on a per-visit basis?
Yes. So I will say that there are some federal proposals underway right now to embed telemedicine services for different models of healthcare delivery that are not fee-for-service. And so you'll see those carried through. Every once in a while, you'll see something for a hip and joint replacement special program where a telemedicine service can be offered. That's passed. Now you'll see it in some of the chronic care working groups and from the Senate Finance Work Committee at the federal level is very interested in embedding certain programs for telemedicine services that are not based on fee-for-service. So it's combined with a lot of pilot studies and federal legislation to see how this is integrated and what you can do there. So not all of that has crossed the finish line yet because it takes a while to get things through Congress right now, if you haven't heard. But those ideas are out there and definitely being fully explored. And on that point, I would say that once the states catch on to it, I think that there will be more state activity there as well.
Other questions? We talked about cybersecurity a little bit. We know we've looked at wearable devices. For example, and some employers are not allowing people to wear those devices because of Bluetooth. You can collect other kinds of information. Is there a concern about that in the workplace?
I think so. I mean, it's an exposure of liability potentially. And so, again, every once in a while you see the fact that I'm a lawyer show up when I'm concerned about liability. I think this is a particular area because there's just not enough information about, how hackers, how other people can get access to that data. And the employer, especially if they give the wearable to their employees, they don't want to be in any way tied to a case, where there's a breach of data. It's dangerous. I will say that, and you know this well, with the different companies, each company has its own culture and relative risk-taking. And so, they'll react and respond differently. And it's not to say that some folks don't currently offer wearables to folks. But, I think it's important to think about the protections, to think through the process, think through the worst-case scenario, what could happen.
Okay. Other questions? If not, last one for you. Can an employer just require one consent for all use of telemedicine that a person has, or does each time they use it, does the provider or employer have to obtain that?
I'm going to give you my favorite answer, which is it depends. It depends on the state, mostly, and because the different informed consent requirements will pertain. It also requires on the provider, again, because different informed consent requirements pertain to different employers or providers.
Okay. Let's thank Allie Willis. Okay, we're going to take a break now. And what we're going to do now is I want to kind of give a perspective on how on-site clinics and employers are functioning and how telemedicine can provide additional support and can be involved. Some of this will be a little duplicative because our previous speakers did such an excellent job of overviewing this. But let's walk a little bit about it. First, again, for this presentation, I'm wearing my other hat. I serve as Executive Director of the National Association of Worksite Health Centers, which is an affiliate of and created by MBGH because we found about a third of employers had some form of on-site or near-site clinics. So now it does educational programs around the country, webinars such as this one. We also advocacy activities, and we focus on a variety of projects, including one focusing specifically right now on performance metrics. So if you want more information about on-site and near-site clinics, be glad to help you with that. Go to the website at NAWIC.org and our LinkedIn group. So as was said earlier, telemedicine defined by the AMA at least included remote monitoring, interactive services, and store and forward, lots of different options. And of course, as also was said, that providers had different perspectives on how it should be used, whether it's an ancillary services or support or something that should be very restricted to certain kinds of providers as well. What we find is that employers are increasingly interested. Towers itself found 75% of members or employers offering some form of telemedicine by 2018. at a potential cost savings of $6 billion. One of the questions is, how do you define cost savings? What is the ROI? It was mentioned by an earlier speaker that one of the vendors computed what would have been the cost of emergency room visits or urgent care services for people not using it. One of the things that we do is we look at what is the cost when people have to leave the work site to get care somewhere else. And so we compute that cost of lost productivity by the salary of that individual and then being gone. We find people are gone an average of 3 to 4 hours when they leave the work site because of traveling, parking, waiting time, etc. A lot of people don't even come back to work. We think that's a significant value of having something on site, and clearly telemedicine can contribute to that. Towers also found that 15% of those visits, emergency room visits, and 37% of urgent care could have been resolved at the lower cost. And as was mentioned earlier, RAND also felt that you could reduce it. In fact, in my estimation, if you look at on-site clinics, near-site shared clinics, urgent care centers, retail clinics, and telemedicine, I think in the next 5 years, over half of primary care will be done outside a doctor's office. It's interesting, some of us talked at the break. How many people don't have doctors who rely on telemedicine or on-site clinics? Again, a survey we did at Nowick found almost 40% or more of people who go to the on-site clinic do not have a doctor, have never seen one. And so it becomes their real primary connector. I don't know on telemedicine whether the experience is like that as well, but the accessibility is really key. So it is an increasing area, offers a lot of flexibility, and does provide those cost savings that we mentioned earlier. This is a slide that one of the other telemedicine vendors used showing a comparison of the cost and time for the visits, whether it's emergency room visits and the kind of potential cost and excess time needed versus an urgent care, an office visit, and then telehealth. So the tremendous savings in time, productivity, absenteeism, and for individuals as well who are thinking, my ear's hurting, I really can't concentrate on work. How long will it take to get this resolved? I've got a meeting tomorrow, or I've got to travel. It really makes a difference. We had an example last time we did a program on telemedicine of someone who was on the soccer field watching her kids on Sunday and was leaving for Europe the next day and was feeling, she was coughing, she was feeling swollen glands, and she had her telemedicine. So she, from the soccer field, called the doctor. He actually viewed her with the camera while she was on the field, gave her a prescription, and she ended up being able to make that trip. So it can offer tremendous opportunities at much lower cost. What we're finding as far as the clinics that are using it, as was mentioned earlier, generally for acute care, but also, as you'll hear later on, more chronic care management, travel medicine, a lot of telederm, telebehavioral health, and used in a variety of ways. I thought it was interesting, how Cheryl described the challenges of these kiosks, but we've also seen these pop-up carts that are moved around different locations in clinics used as well to do this. The typical telehealth scenarios we find is that it is available for everyone covered under the population, and particularly in those remote locations, offered in a variety of locations. And then, of course, as Allie mentioned, the regulations make a big difference in how it's offered and how it's billed. But a key thing that, again, was mentioned earlier that I want to emphasize, we don't want on-site clinics or telemedicine to be another fragmentation of the healthcare system. It's got to be coordinated in some way. And so we really encourage our members and employers and the vendors to make sure that if the patient does have a primary care doctor, they have access to whatever is offered or done by the on-site clinic or the telehealth vendor, or they make arrangements so that it is a consistent record. There's a concern that someone will go to the clinic or go to the doctor and then go to telemed and get 3 different prescriptions for the same drugs. We want to make sure those are not for controlled substances or other things, but you've got to always be concerned about this fragmentation and duplication of services, and so it's important that we oversee this. When I look at one employer's experience and when they ask people, what do you have done if you didn't use your telehealth service, you can see most of them would have gone to primary care or urgent care services. Some had a rural clinic available, and some wouldn't have done anything. So every employer is going to be different. This is one health plan's experience. Some of the risks, though, that we are concerned about through the on-site clinic is that lack of coordination, which is really key. I mean, if there's anything employers are frustrated about is the inability to doctors to talk with each other and patient to have information. The need for the right type of cameras. The phone cameras are just unbelievable now. And in fact, there's some employers, I don't know if it was IBM or someone who's actually sent employees a device to connect to their phone to check their blood pressure, I think it is. It's amazing what can be done in a variety of ways, and it becomes much more broader than what we used to have in these the nurse call lines and the limitations we had for telehealth. You want to make sure that the equipment's not malfunctioning. We are concerned about overprescribing by primary care. We know there's a lot of patient demand for prescriptions every time they see a doctor. It won't surprise me that when they're on a telemedicine call, it's the same thing. They ask the doctor for a prescription. We know some vendors are monitoring what the doctors on their staff provide through telehealth. We want to make sure that that's done correctly, something an employer needs to address. Security and privacy is the key always in getting people to use these employers-provided resources. It is the number one reason that on-site clinics fail is the lack of confidentiality and privacy. So telehealth is the same thing. You've got to make sure that people feel comfortable that their information will not be shared, that the transmission of the information or the video is not showing up on everybody else's TVs or on their computer screens when someone's talking to a doctor at work, things like that. Employers need to be assured the providers have the training to communicate. You know, they say that, if the doctor at the bottom of the medical school class still has an MD degree. Every doctors are different. They vary. Well, they clearly vary in communication skills. So not everyone can talk through a computer screen or on a phone to a patient. It's important that those people are evaluated, and that should be some kind of criteria. So we always recommend that that's be done. Again, on the on-site clinic world, poor providers is the number 2 reason clinics fail, because they don't communicate, they don't understand well, they don't fit in with the culture, etc. It's really important. And lastly, the vendors need to be clear on what they can do and when the person needs to be seen by a doctor. You know, you can't get on there and they can't communicate and understand everything that's being done through a device. So it's important that those limitations are listed out. Some of the challenges which were mentioned before that we find in clinics and in employers generally is the wide variation of regulations. Many employers have the same challenges with clinics. Certain providers can or cannot prescribe. Some can be used and not be used. It's important that the employer who has a clinic or those who have people all across the country do understand what can be done. Not all telehealth vendors, we understand, can operate in all states. And so that's another question. They may not have a physician's license in those states to be able to use, so you have to ask those questions. Low cost sharing is key to get people to use this, as well as the broad communications. We'll talk a little bit later about engagement, but there's no doubt that many of our members have a variety of clinics or wellness programs or telehealth, and only 10 to 12% of people are using them because it doesn't come to mind. They don't remember to use it. They don't understand, or they're concerned about the cost. Any kind of subsidization would clearly help out on that. And the utilization is going to be key, and we'll talk about that in the future. So that's essentially what we're seeing with on-site, not much different than others. But if you want more information about it, please feel free and let me know. I'll be glad to take any questions anybody has about the on-site clinic world. If not, let me introduce our next speaker. Now, I mentioned briefly that one of the things we wanted to do was address the fact that you can now do chronic care services through an on-site clinic. And Mike, so our concluding session is, as I said at the very beginning, we want to get down to what the employers are doing and their experiences and their challenges. And so to introduce our panel, I want to invite Judy Hearn, MBGH's new Director of Strategic Initiatives, who previously was at benefits for Packard Reynolds Corporation, in parentheses, hefty backs, so that you could hear more about this approach. So please welcome Judy Hearn.
Hi, I'm going to ask both my panelists to come up while I introduce them. First, Susanna Pajeski is the manager of U.S. Health Plans at Abbott and has been with them for over 10 years. Susanna develops, manages, evaluates and implements benefit strategy and new benefit program, and provides benefit recommendations to management to include employee and financial impact. She's responsible for the selection, evaluation, and ongoing management of benefit vendors and consultants, and she leads a variety of implementations of both programs and vendors. Next, Jennifer McMurray is a PharmD from the University of Illinois. She works for Walgreens Boots Alliance as their Director of Strategy and Planning. She is responsible for the successful strategic planning, integration, and promoting of products and services into the Walgreens team member healthcare and benefit programs. This includes assessing and prioritizing company initiatives and working closely with product delivery areas to deliver products, services to the team member population. So I'm going to let you know that in addition to having these two panelists present with me today, I had feedback from a number of other employers who were also interested in contributing their perspectives, but could not be with us actually today. So I'm going to start first, though, by having Susanna take about 2 to 3 minutes, giving her experience, and then Jennifer, and then I'll give my own experience from my prior employer, and then share some other comments, and then we'll do questions.
Okay. So, my name's Susanna, and we at Abbott, we recently just launched on telemedicine. So we went live with telemedicine on 1/1. We have quite a dynamic, I guess, plan offering where we service about 16,000 active employees and about 3,500 retirees. So we have 2 different TPAs. We've got 2 different designs offered through each of the TPAs. So one of the things I think that facilitated our launching of telemedicine is that we have one plan design. So we have 2 different offerings amongst both TPAs, but one plan design. And then we were fortunate enough to have one telemedicine provider basically provide services for both of our TPAs. So from the get-go, we were pretty fortunate to have it. Our implementations went pretty smoothly because of that. Then we also have really good relationships with our TPAs. We have our care coordination services, which are offered through our concierge service. So implementation was really bringing the core team together, which was our TPAs, our concierge services, and us to the table. So we have one plan design. We designed the benefit across both TPAs to be delivered the same way, basically turned on the benefit. We do not do benefit fairs at Abbott. We do what we call roadshows. So over the past 2 years, we have really focused on educating our members on the financial attributes of the plan design, how they work. So as a team, we go out to our facilities and we provide a pretty in-depth open enrollment communication strategy where we do side-by-side comparisons. So we use that platform to really, I guess, introduce telemedicine, what it does. For some of those folks that were moving over or considering our high deductible plan, it was an avenue to say, at the beginning of the year, you're building your HSA. You're always, what if I don't have money? Well, telemedicine, using them versus having to go to an in-office, the cost was a lot cheaper. And so it was a hot moment for many folks to say, you know what, if I do have that common cold, I don't have to go to the office. I don't have to go into the office. I don't have to get my kid up early in the morning. And so we did a soft launch where that was the only piece of communication we did during our open enrollment. We chose not to deliver member kits until after the ID cards went out. So we just recently delivered member kits last month, and the feedback we've gotten is we've got about 327 folks that have registered. We've had about 66 consults, which isn't a lot, but it is when you take into consideration the fact that we had a soft launch. We just communicated. Members are just getting their ID cards. We are looking at continuous communication of the program through incentives by training our concierge care providers. They have the opportunity to talk to members, and so they are continuously reminding our members that call in for services that, hey, by the way, remember you also have telemedicine as a different option. So for us, thus far, feedback's been really good. We've had folks from the manufacturing facilities that have been excited about it because they're getting access to care late in the day when the doctor's office isn't open. And then we've got folks in the offices that, are coughing or have pink eye, and, we're like, you might want to call a telemedicine. That's our experience so far.
Great. Jennifer, what about you in Walgreens? Yeah, so we have a little over 100,000 team members enrolled in our health plan. We do offer 7 medical carriers across our exchange, and of those 7, we've been able to plug in our telemedicine provider in 6 of those, and the 7th is Kaiser, and as you know, Kaiser has its own network. But of our 6 providers, we were able to plug our telemedicine services in. We have 3 different plan designs our team members can choose from, but regardless of the plan design and regardless of the 6 carriers that they select from, they can receive telemedicine services for a flat $5 copay. So that has been our incentive to get the utilization of these services aware, the awareness part of it, but then actually the utilization of the services. So we launched January of 2016, so the program has been in place for a little over a year. We've had close to 3,000 registrations, so activations onto the account, onto the service, the platform, for when they do have that issue or pink eye or strep throat, they're ready to go, which is close to 3% utilization. We were thinking maybe 1.5–2% use, but getting the 3% we're very excited about. Obviously, our leadership and us want that much higher, so we are working on some additional strategies this year to bump that up. Of those 3,000 that have registered, close to 1,700 of them have used the service. So about 55% of the individuals that actually activate an account go ahead and use the service. So what we're finding is it's a little bit more top of mind for these individuals once they've taken the steps to activate the account. It's more awareness that they have this service available for a flat $5 copay. And then those that have activated an account, 55% of them are using it. Of the ones that have used it, we're finding that 25% of them have used it 2 or 3 times already. So, and that's just over a 12-month period. So once they use it, we're finding that they're coming back and using the service again. We have received a handful of testimonials from our team members, obviously with the holidays coming, the 2 a.m. call on a Saturday night with the ear infection in their child. So we have received some great feedback from our team members about the availability of the service. We do have this available through our Walgreens.com website. So it is something that is promoted to consumers, and obviously we want to lead that into our team members, for our own team members to have that same experience as they also talk to our consumers walking in the door every day. So it's gone off very well for the first year. In January of 17, just last month, we added behavioral services to the platform, and that is also available for a $5 copay. So one of the pieces that we found is the awareness of the service is also the team members being comfortable with the service. Is this a real doctor? How do I just talk to someone over the phone without them physically seeing me? So what we're trying to do is educate the team members that this doctor that they use can one time at 10 o'clock see an appointment face-to-face, but then have a telephone visit at 1 p.m. because of the schedules and the way they're trying to maximize their workday as well. So we're trying to get our team members comfortable with using virtual care services, whether it's through our telemedicine for acute services or behavioral services. And we also just launched dermatology visits in January with a virtual care dermatologist provider. So starting to get into the space more. We're actually launching tomorrow our dermatology services and then doing more of a broader communication next week. So just getting into the space is new for us, for our team members to use, and then as we communicate it, each time we see our activations peak a little bit and then they'll drop down, and they hear about it again and they'll peak a little bit and they'll drop down. So we're finding that the more we're getting that a little bit more top of mind, that they do create those accounts and then it becomes top of mind for them to use the service. So we've had good success over the last 13, 14 months or so.
That's great. Thank you, Jennifer. Last year, I was responsible with my prior employer to implement telemedicine, and we decided right off the bat that we were going to offer an incentive of the first visit free for not only the employee but any family member. So if a particular household had 5 people and they each used a telemedicine visit, we were going to give each person a free visit in order to encourage utilization. We also made sure that we had a lower copay for the visit, except for our HSA participants. They were being charged the full visit cost, but then once they met their deductible, we were also going to offer them the same copay per visit, which I think resonated. And I was watching stats week by week by week, watching the activations growing. We chose to implement in January. We did not do any messaging during annual enrollment in that prior October because we wanted to make sure the messages were not lost. We also then decided to do a special incentive launch during the month of February so that anyone who had activated an account either during that month or the prior month, that they would be eligible in a raffle for one of 4 different gift cards. We had more activations during February than prior, and it was also our biggest month of activations. Overall, though, I'm a little jealous of the Walgreens stats because we did not have the number of people activating an account. And by the end of December, I had just gotten over 500 activations, and I'm including employees and any dependents as well. And we had about 19,000 eligible for the benefit. So we were disappointed that we didn't have higher activations, but we got great response from people who actually used the services. They were very pleased. One of the concerns that I had when we were looking at implementing was we didn't want the telemedicine option to be an easy way to get a script. And we found in our stats that only about 78% of the visits were actually getting a script. So that kind of calmed our concerns a little bit. Susanna, maybe you can tell us first, what kind of training did you do with your HR team or other managers and supervisors?
So for us, prior to open enrollment, we do have we call our directors, and we basically give them the training that we're going to be out in the roadshow, the presentation. So we introduced it to them at that point in time. As far as training managers, HR managers, we didn't. We haven't yet. What we are doing, though, is we are going to train or provide additional resources to our occupational health nurses in the upcoming months. So we're going to continue to get the messaging out there, and we do this with all other vendors that we have. They've got monthly meetings, so we're in there, we have a topic, we discuss the topic, we're hoping that they continue to roll it out. But for us, it was really just giving the directors the heads up that these are additional services and vendors that we're going to integrate into our platform, and they themselves then could educate the members and give the training as they needed or point them in the right direction. We provided links to our telemedicine provider on both our enrollment site and then our care coordinator site. So we really wanted to navigate the person that was using it to get them to the right resources. But really, that's what we've done thus far. So we still are trying to come up with an annual communication platform to say, when is the right time to introduce this benefit along with other benefits? One of the ideas that we've had is during, we have a lot of folks of us that have college kids. It's a great avenue for college kids to register themselves. And so what type of communications do we want around going back to school? So those are some of the ideas that we've got going on right now. Great. Jennifer?
Yeah. So we have about 200 benefit professionals, HR professionals across the company who oversee the corporate stores and the distribution centers. So when we first launched the product benefit offering, we did have a benefit spotlight, I guess you can call it, with our benefit champions, these 200 individuals, where we sent them some educational pieces, just one or two attachments on just overview of the service, the benefit, the incentive, the copay, and the availability of the offering. So that's our communication path with any benefit, new benefit coming or an enhancement that's coming. It's kind of the monthly spotlight. So those individuals would receive that information, and they would take that and weave that into their meetings that they would have, whether it's with their district manager or with their area distribution center manager. So we give them the tools and the resources to bring that information more on the ground with leadership and managers and those team members. We are also leveraged our care coordinators because we launched actually last month a care coordinator program with our 4 national carriers that help the team members maneuver through the healthcare system. So it's not, I need an ID card, sure, let me mail you one. It's, I'll mail you one. What do you need that service for? Are you trying to use it for X, Y, and Z? So having that conversation. So with the data that our medical carriers are sitting on, which is a gold mine of data, we're working with them to come up with some initiatives to say, what about people that have used the ER for services that our telemedicine provider offers? Can we do an outreach campaign to those individuals, letting them know about these services? Because if they're going to go to an ER on a Saturday night for an ear infection, they're going to go to an ER again for the next ear infection that happens. So it's getting in front of those individuals with our medical carriers' data to let them become more directly aware of the services than just casting this huge net to 100,000 team members. It's, okay, let's go after these people that have used the service. Or what about millennial moms? Or any age, it doesn't matter, but what we're finding is millennials are more open to the services that are available through telephone. So instead of casting a little bit of a small, wider net for those moms with young dependents, maybe we hone in on more of the millennial moms to start and then build on that. So we're trying to find ways to get our care coordinator program using data to create awareness than just a communication campaign. So that's some strategies that we're working on right now.
Great. One of my experiences has been to, anytime I had an opportunity to get in front of the field HR team, was to remind them. And in my prior experience, I was constantly reminding people, remember, we're giving the first visit free. We were only doing that in 2016. So during that final quarter of the year, I was constantly saying, and remember, that free visit is going to go away as of the end of the year, so everyone get excited and try to encourage. We did have one of our CEOs have an opportunity to use the service, was going to be traveling, actually needed to have a script refilled and was out of options and wasn't able to reach his other physician. So he was able to successfully get that script refill, pick it up, and on he went with his trip. So it worked very well for him. Let's talk a little bit more about what kind of concerns, if any, you had when implementing. Do you want to start, Jennifer?
No concerns at all. It was more just, are our team members going to be aware of the service? Are they going to find the service beneficial for them? The copay obviously is a large incentive for them. They go to a provider today, or urgent care, emergency room. Half of the individuals, when they complete
when they complete a service through our telemedicine, they are able to do a survey at the end. And we probably get a 20% response rate on that survey. Half of the people that use the service said they would have gone to an urgent care if the service wasn't available. 3% would have gone to an emergency room. 20% would have gone to a PCP, and we have the retail clinic. So obviously, we're creating a very convenient option, a low-cost, quality option for our team members. And it was more about, is this going to resonate with them, or are they going to want to talk to a doctor over the phone and feel that they're still getting that same care, than bringing their child in at 2 a.m. to an emergency room visit, on a Saturday night, or visiting their doctor that they may not even be able to get into the next day. So with the testimonials we've had, with the registrations we've had, and then all those registrations, the use that we've seen, we feel that this was a need for team members. And then as they begin to use it, as we create additional communications, we're working on a video right now that will kind of tackle the virtual care, healthcare use, than just going after acute care or behavioral services. So really trying to paint the picture of, you don't have to go physically to your doctor anymore. We have virtual care, and you can get that same quality care for certain acute needs or behavioral services through those mental health specialists. So no concern, more excitement around a different point of care our team members can choose from. And it's really a low-cost, convenient, quality care for them. So it's been good. Hopefully getting more enrollees throughout the year.
Great. Susanna, do you have any?
Well, you guys are much more generous on your copays than we are. We really just rolled out the program. Copay was basically member-paid copay. We do not provide any assistance with the copay. For us, it was more the messaging. We didn't want the message to be, we're providing you the service because we want you to be at work. So for us, it was more how, we just wanted to roll out a convenience, an additional service. We at Abbott care about you. We want to make sure you have options. And for those millennials that we're attracting, they love anything that is app-based or, right at their hand. So it was more of a convenience. And so we really were trying, even just in our communication strategy, not to say we're rolling this out because it's a way for you to, be at home or be at work and not miss, or you can do this from the convenience of work. We just rolled it out as it's a convenience, it's a choice, it's an option, and so that's where we were most cautious on. But other than that, it was a pretty effortless rollout, I'm going to say.
And Jennifer, you made a good point about looking at populations that maybe have a high emergency room usage, and that might be one of my suggestions to other employers, that if you have particular locations and your data can show you that, gee, this location in Jacksonville, Illinois tends to have really high ER usage, and 20 to 30% of it is for non-urgent reasons, that they might be a great population, and then do some targeted messaging. We put up posters, and we would rotate or refresh the poster images so that, in a manufacturing environment, we didn't have email to communicate to them. So we would use much of that right on site in the plants.
I'm going to say that one of the things that we were cautious about was with all of the different laws within the states and the regulations and what states can provide what services, I was a little hesitant to say, to expect, I guess, some states to actually show us proof that our employees have used it. And up to date, this is just a month and a half that we've had this program. We've already had members in 12 different states utilize the services. So that's a good number for us and a good way to say, it doesn't matter where you are nationally. We are targeting and getting utilization from members where I didn't think we would.
That's great. Do you have any comments about reporting what you've seen, either with kinds of members that have used the services, or?
We haven't broken it down by state. We do have team members across the 50 states. I think Arkansas is the only state that does not provide telemedicine services. Also one state. But we're focusing more on the stats of activation, utilization, using it more than one time. Are they coming back to use the service? I think the video within our company is going to be helpful because we're going to bring in more of the virtual care, have some team member testimonials as well as a leadership piece in it. So you're kind of hitting all angles there, but very short and sweet, all in probably less than 2 minutes. So those are prescription use. We are seeing about 77% of the services result in a prescription. So same stats that you were seeing as well. So it's not just a seeking out script. I mean, how many people are running out to get an antibiotic? But you know that they're just not prescribing an antibiotic for every single case that happens because about a quarter of them aren't resulting in a prescription. So it's been good for us and just trying to keep the communication going with team members.
Yeah, I agree that constant communication is really vital. We were finding last year that we had a great percentage of men that were using the service as well as women, which is exciting because we know sometimes the male population does not tend to utilize medical services as often as an employer might want. We also found that the time of day of the services was more happened actually during the day rather than like the wee hours of the morning. So that was very interesting to me. So the stats, I'm sure, will continue to provide further insight and so forth. I think at this point I might like to open it up to the audience to see if they have any questions from any of our panel members.
Any specific questions? If not, let me ask our panelists. First, thank you again for coming today. I assume you're both paying a per member per month or something like that. What's the ROI? How many of your people have to not go to the emergency room or have to not take good care for you to talk to your CFO and says, yes, this is paid for itself? Or do you just view it as an additional benefit and its attraction and its recruitment and retention, and you're not that concerned? What's your perspective?
Well, for us, it was really just an additional benefit. It was something of convenience, a nice add-on for our benefits, for the employee morale. Abbott's very paternalistic. We like to take care of our employees. So for us, we're going to look at the number. I mean, we're going to look at the savings to be able to prove that as we bring on additional benefits for our employees, they do have a benefit, financially down the road, and they do pay for themselves. So hopefully we can add on additional services that are available. But as far as an ROI, we didn't set a threshold to say this is how we're going to value this benefit as beneficial for Abbott.
Do you have a target of engagement?
I would like 10%. I know, that's a high number, but I think that having this benefit, slow rollout, very silent, we're seeing engagement. I mean, I've had 327 registered members with barely any effort put into it. I'm hoping to get at least 3,000 by the end of the year, and then I think that's probably going to be where I would say successful.
So we've looked at the utilization, the engagement. The savings is paying for itself, so we are seeing some savings to the medical plan. And then obviously presenting to leadership, we need more because to see the savings come through the medical plan to avoid ER and urgent care visits. And it's also giving a benefit to our team members across the country. We allow our team members to use our healthcare clinics. And you probably are aware that we are partnering with health systems in certain areas of the market, but they're not available in every single state. So those clinics, whether it's a healthcare clinic or a health system clinic in our Walgreens stores, our team members can get a $5 copay by utilizing a clinic. So obviously our team members who are not near one of those clinics say, well, I don't have a clinic near me. I want to be able to have that convenient, low-cost option as well. So this allowed us to meet the needs of our other team members who are not near one of those in-store clinics. So it's been a very positive message for our team members. Again, another option for them to use a service that's growing in the market and being, an employer that's adding this to a benefit kind of a little earlier in the game than other employers. We're very proud of that and excited. It's just getting the team members to recognize that this is a point of care that's going to stay, and it's a convenient option for them. But the savings, we are seeing that in the medical plan. It's just now getting more activations and use through it.
Do you have a target of engagement?
No. I think, we were estimating 1.5% to 2%, and at the end of the year, we hit 3%.
Mm-hmm.
All right, we'll take it. And we'd like to get it up to 5%, 6%, to double that at least. I don't know if 10% is going to, because our provider that we're getting our services for, their employers are seeing about 5 to 6% activation. If we can get to 6%, that's great. If we can get more, then even better. So we don't have a target per se, but we are looking at growing it.
Let me ask, if I can, Paul from Telemedicine. On your book of business, is there, microphone please, is there a target that employers set or an expectation of what percent to be engaged in general?
Absolutely. And we measure things a little differently. We're really not measuring success on registrations because registering for something doesn't actually drive a benefit at that point yet. We're saying to get the ROI, you have to actually use it. So our target is, our ROI calculation is pretty simple. It says that we're going to take average number of consults or visits within a year and divide that into the number of average employees. And our employer book of business does run around, well, you'll know it better, 10 to 12%, probably closer to 12% for the most current 12 months. And our minimum thresholds are, and this is again the 1,000+ marketplace, which is pretty much right here, is a floor of about 5. If we go below 5, we're really not happy about the results and are continuing to drive the engagement to get it closer to 10. And interesting corollary, we have, Cheryl, you mentioned there's that third model, that consults included model, where you just gross up the PEPM and everything's included gratis. That book of business runs well into the 20th percentile, pushing 30%.
The other thing is registration. Should use about 90%. If you were to do registration,
Okay. You want to say that?
Thanks.
So if we were to think about, for that same, our employer book of business, if we were to think about of the number of people who register or activate and then ultimately use the service, for the trailing 12 months, it's 90%.
Let me ask you the question. Do you have performance guarantees on your telemedicine vendors? And if so, what are they?
We have performance guarantees on if they do call, average speed to answer, turnaround time on issue, resolution, but nothing, those are really the PGs that we have.
Yeah.
Yeah.
Same. Yeah. Nothing different, but some of the feedback I got from other employers that I spoke with said that they were disappointed with their utilization. And when I hear 10 to 12%, I'm thinking, oh, really? I'd like to hear from those employers on what they did and how they got there. Because our perspective was, we thought we were doing all the right things, different kinds of messaging, incentives, and just didn't see the usage really. Although I have to say that the reporting that we got back would show, based on a survey response by that individual who used the service, where would they have gone, that we could see that we were breaking even, which was our initial intent, to make sure that we would break even with the benefit in year one. So.
Question? Yeah, if you don't mind. You've got a very diverse population at Abbott. Judy, you have a diverse group. They offer translation services? Do they offer telehealth? Is there an issue with languages, or is there cultural issues in using telemedicine, telehealth? What's your experience?
So for us at Abbott, we're so new into it. So we did think about, we have a population. We have a variety of population on the West Coast. We've got in California, Arizona, a lot of our manufacturing facilities with English being the second language. So it's something that was considered, because of the fact that we didn't expect high utilization right off the bat, it's something we didn't truly, didn't stop us from implementing telemedicine. But right now, we understand that there might be an English barrier, but since we use, you have to speak English and write it effectively in order to be employed at Abbott. That's one of the reasons why we felt comfortable that the services that are provided today are consistent with basically our motto at Abbott. Providing translators, having those types of services is always beneficial, but at this point in time, without seeing further engagement, it's something that we'll explore down the road.
Yeah, and same. It's English-based, and if they do have to call in, but the physicians that they're offering, I haven't looked at every single one of them, what language they speak, but through the information that's provided when they do select a doctor, that they have a background, what their specialties are, what spoken language, so they are able to choose. Now I haven't looked at what every single, but it's their network of providers. But we haven't received any complaints of having providers that don't speak their language, because we do have people across the country. But if it is something that is missing in their network, we would bring that to their attention. But it is a selection criteria they can choose when they pick their doctor for that point of care.
Yeah, I would agree, because with the provider that we were using, we could see who the doctors were, and you could either schedule an appointment at a certain time or see someone who would be available immediately. And I know when I used the service, I wanted to make sure I got a prescription, and I thought, now let me see which providers do I think might help me the best. So I kind of liked it, and I called from work, from the privacy of my office. I got the prescription I needed, and it was a win-win. So.
Okay, we'll delete that.
The one thing I think is really interesting to hear both of you take the perspective of a multi-year view on how the program will build from an impact perspective. I think that's something we really very clearly see is the difference between, we monitor very much the cohorts of the first year, the second, and the third, because obviously it needs to be a cumulative build, and I think that that's something as people look at measuring effectiveness. You really do want to see that ramp, and the ramp should be exponential, really, in terms of how it grows. So that seems consistent with what we've seen.
Other questions or comments? We're just about out of time, but let me ask one more.
I think we have one.
Oh, Reagan, I'm sorry. Go ahead, Teresa.
Can maybe the vendors speak to industry-type engagement numbers? For example, manufacturing, white collar?
It's interesting. It's I can go industry by industry, and I can find companies that are doing very well, and I can find companies that are not doing very well. And from our end, it doesn't seem to be heavily industry specific. It happens to be more, is the client going to engage or not? And again, I can go to banking, I can find clients that have done exceptionally well, and I can find ones that are sub 5%. I can go to manufacturing, same thing. Common denominator is the ones that are not performing, the communications are not happening at the level that we'd like to see them. And a lot of times it's not us, it's roadblocks being put up. We've had very large clients that we need to engage. We're not seeing utilization, and they're blocking at every pass. And we say, we can't help you improve the game if you don't work with us. And then the clients that we tend to see that are seeing 20+% utilization, it's a very direct communications campaign. We're supporting it completely, but then they're going beyond that and taking it on their own as well. But we're here to drive that engagement. It's really not industry specific. Stephanie, I don't know if you have any additional comments.
We are also seeing a connection between the copay amount. So we're seeing double the engagement if there isn't a copay. So that's kind of an interesting finding, after 2 million plus telemedicine visits. So I think that's kind of interesting. And so Stephanie and her team are studying that.
So it's a free service then? That's what were you saying?
No, I'm not saying that it's a free service. It's the way the benefit design was put in place by the employer, that they wanted to either be on par with other physician copay or, so, when we see that, there's just a huge difference in participation. So there isn't another barrier put in place. So it's either equal to what they pay if they went to a brick and mortar versus going through telehealth. Does that make sense?
Sure.
Okay.
Just to camp on that, this resonates heavily because, again, multiple years of measuring this, lots of consults. When we look at the bank of clients that the member has full responsibility, it's a $45 copay, we tend to see utilization around 4, 5, 6%. When we have member liability set anywhere from called $0 to a $5 copay, we tend to be in the 20% range utilization. So for every 1,000 employees, you're seeing 200 consults in a year.
Gotcha. So last question, Jeff, for Walgreens, you talked about your clinics. How do you integrate telemedicine into clinics? I mean, you have a vendor who runs the clinics for you, and in the retail clinics you have, in Illinois, you have advocates running it for you. So is the telemedicine vendor integrated with those two, or how does that work?
No, it's, well, the telemedicine services are available, whether it's phone or telephone or video. I'm thinking FaceTime, like that's not what I want to use. So you don't have to physically go somewhere to use the telemedicine service, but the advocate may have services of their doctors that are providing virtual care. So as part of the advocate system, I would imagine some of those physicians within that system see a patient face-to-face and then turn around and have their 1 o'clock appointment virtual care. So it's the network that our telemedicine provider forms and the relationships that they have with the different health systems across the country. And if Advocate's part of our telemedicine service, then great. I don't know if they are. I haven't explored specifically each of our health system partnerships. But I let the carriers and I look at our telemedicine provider as kind of the carrier, and I let them build a network with the providers in the market that want to partner with them and offer the service. I let them do that job.
The medical information?
I don't know what the EMR, the platform that they sit on. I'll actually take that back and look at it. It's a really good question. I'm not quite sure the EMRs that are used between, and even Walgreens uses an EMR. So I know our healthcare clinics use Epic, so I'm not quite sure of our providers where all that funnels into. I would imagine some do meet.
All right. Thank you. Well, let us thank our panel, Judy, Jennifer, I want to thank our sponsors, Teladoc and Berta, for their support, and I want to thank you for all taking the time today. Please do complete the evaluation forms and leave them here, and then hopefully see you next week at our data management program. Thanks all very much.